So hello everyone, my name is Matthew. I'm one of the residents of PGY3 here, and I'm going to be talking about the histologic variants of bladder cancer today. And these are things that will show up on your path reports after TURBT. And I know for myself, seeing a couple of histologic variants, I didn't really know what to do with them. So I started reading a little bit, and it turns out they actually matter quite a bit, and I hope that we'll be able to discuss that more today. So these are objectives. So we're going to talk about the different major histologic subtypes of bladder cancer and how their prognoses differ from garden variety urothelial carcinoma. We're going to talk about how the therapeutic approaches change to these subtypes based on the different behaviors of the disease. And we're also just going to talk a little bit about some of the new upcoming molecular targets that are available for these different subtypes of cancer, which is an area that's actively evolving. I'm going to be using a bunch of abbreviations on the slides, and you can see them here. Have a read. And so bladder cancer is a very heterogeneous disease. Starting out, I thought it was just urothelial carcinoma, and that's it. But it turns out that there's all these different subtypes, and there's some of them aren't even urothelial in origin. Some of them have more in common with colorectal cancer than they do with bladder cancer. So it's not really surprising then that the behavior of these diseases is radically different, and the approach to them is different as well. Variant histology is not particularly uncommon either. There have been several large retrospective contemporary studies that peg the incidence of variant histology somewhere between 15 and 25%. Some of these have more clinical significance than others, but they're quite prevalent. They're out there, and so that's why I think it's really important to talk about this and to make sure that we all understand. For brevity's sake, you can see here there's a massive list, but for brevity's sake, I'm going to be focusing on micropapillary, squamous, adenocarcinoma, and small cell, and that's mostly because these are the four types for which I could find the most evidence and have some of the bigger clinical implications. So we'll start by talking about micropapillary. Micropapillary is a variant of urothelial carcinoma. On histology, I'm sure I'm going to butcher this, but they present as clusters of filiform neoplastic cells without a central vascular stalk, like a micropapilla, if you will. This histologic subtype was first described by a pathologist named Amin at the MD Anderson Cancer Center in 1994. As we'll discuss, this micropapillary disease is a very aggressive variant with a propensity to invade and spread beyond the bladder very quickly. And there are poor outcomes as a result. On pathology, any amount of micropapillary disease is significant and should alter management. There have been a lot of studies now that have attempted to correlate the amount of micropapillary disease on pathology to difference in prognosis, and so far they've all been negative. So any amount of micropapillary, even a small focus, should be treated like a pure micropapillary tumor just because of the aggressiveness of this disease. So as you're going to see, a lot of our data comes from MD Anderson. They're the Bladder Cancer Center. So this is one of the first series on micropapillary and one of the largest. As you can see, it's a relatively rare disease, anywhere from 0.7 to 2% of all bladder cancers. So they had a sample size of about 100, and what they found was that 45% of patients had muscle-invasive disease at presentation, which is significant. Furthermore, over 90% of patients who showed up had T1 disease or worse. In patients who were treated with cystectomy upfront, so within 3 months of diagnosis, a quarter had node-positive disease already. So it's not surprising that 5-year overall survival was not great. 51% is what they reported. And probably most strikingly, for patients with micropapillary disease, patients who had non-muscle invasive micropapillary disease did not survive any longer than the patients who had muscle invasive disease, which I think really indicates what an aggressive subtype this is. Data from the Mayo Clinic shows similar story. They had 73 patients, 2/3 of which had T3 or T4 disease on presentation. 10-year cancer-specific survival was 31% in this cohort. And they went a step further and actually matched their micropapillary patients against, I think, 5 to 10,000 patients with plain urothelial, and there was a significant cancer-specific survival difference. 53% of people in the urothelial group made it to 10 years versus 31% of the micropapillary. Interestingly, though, they then stage matched the micropapillary patients to their urothelial patients. So you can see that from the bottom right-hand graph here. The bottom left-hand Kaplan-Meier curve shows just pure overall survival. Top line is urothelial, bottom line is micropapillary. You can see the separation there. But when they matched by stage, there was no difference, which is what you see in the bottom right Kaplan-Meier curve. So perhaps we can attribute the poor survival to just the fact that micropapillary tends to present more aggressively. So one of the big questions in the management of micropapillary is whether or not we can attempt to manage non-muscle invasive disease with intravesical therapy. As micropapillary is a variant of urothelial carcinoma, it would be reasonable to think that this might have some efficacy. So the MD Anderson group, again, tried to answer this. They had 40 patients who were diagnosed with T1 micropapillary disease, and 26, so about 40 of those went to BCG. 26 had cystectomy up front. Of the BCG group, results were dismal. 75% had a recurrence. 45% progressed to muscle-invasive disease or worse. In fact, and they progressed quickly. It only took them about 8 months on average, or the median 8 months to progress to muscle-invasive disease. In comparison, the radical cystectomy group did quite well, and there was 100% cancer-specific survival at 5 years. And you can see that the Kaplan-Meier here, blue line at the top is the upfront cystectomy group, and the bottom line is the primary BCG group. So based on this, MD Anderson concluded that all patients with any amount of micropapillary disease, regardless of stage, should have an upfront cystectomy, and that was what was best for survival. That's not really the end of the story, though. The MD Anderson study was small, was retrospective, single center, and so not to be outdone, MSK also put out their own data on T1 patients with micropapillary. They had a bit of a smaller group of 36 in total. They had 15 who had upfront cystectomy, 21 who were put on BCG. And they actually found no difference in 5-year cancer-specific mortality. There was a trend towards a benefit for cystectomy, 17% at 5 years versus 25% in the BCG group. And there was also a trend towards decreased incidence of metastases. However, neither of those were statistically significant. So based on the lack of statistical significance, the Memorial Sloan Kettering group actually cautiously concluded that BCG was still a reasonable therapy, but it was they also conceded that they didn't know how to select the patients who would respond. The argument against both these studies is that they're small, single-center, and retrospective. So Sway and colleagues actually used the American National Cancer Database to find 869 micropapillary patients. And they, because it was an administrative level database, they could only really stratify into cystectomy versus bladder-preserving surgery. Bladder-preserving surgery was TURBT or partial cystectomy. So essentially it was cystectomy versus everything else for T1 patients. And they didn't find a survival difference either. So really, the evidence is somewhat muddled. You have MD Anderson who says, cystectomy for everyone. Memorial Sloan Kettering who says, consider BCG. We don't really have any good evidence to inform our decisions on this. And so I think it's still up to interpretation. What we do know about micropapillary, though, is that it is very aggressive and has a high tendency to get outside the bladder quickly. So personally, I think that if that were my bladder, I would want it out early, as opposed to trying BCG and potentially failing and progressing. But you can't really say for sure at this point. So yes. That's what I read. But I mean, not necessarily by definition, but almost always it's high grade. I don't think I've read anything about low grade micropapillary.
So we're talking about G3 and micropapillary.
Yeah. Right. Yeah. They're high grade. Okay.
Can I ask them, do the reports actually have high grade? Small.
Yeah. Okay.
It's not
Yes. Thank you. So, another question then would be, given this disease's aggressive nature, what about adjuvant therapies to try and contain it or reduce, recurrence or extravesical spread? And neoadjuvant chemo actually has had some research done into it about its efficacy in combination with cystectomy. So, in a National Cancer Database study, they found that there was a decreased incidence of T3 or T4 disease at cystectomy with neoadjuvant chemo. And that was relatively significant. 46% of patients who had neoadjuvant chemo had T3 or T4 disease versus 73% who had upfront cystectomy. However, there was not a statistical overall survival benefit. Similarly, MD Anderson had a small series of 23 patients. 60% of those patients were downstaged at this time of cystectomy, which is a surrogate marker for response to chemotherapy. But again, small study, no overall survival benefit. Memorial Sloan Kettering, again, no survival benefit, but 45% of their patients were downstage to PT0 at cystectomy. And they examined this particular PT0 group and actually found significant benefits in overall survival, cancer-specific survival, and recurrence. You can see the Kaplan-Meier's here. Pink lines at the top are patients who were PT0 at the time of cystectomy, and the green lines are patients who had any amount of residual disease. And you can see a significant survival benefit. So they concluded that if you can get someone to respond to neoadjuvant chemo and their disease is completely treated, they can do very, very well. So again, as you'll see as a common theme, we don't have any real level 1 evidence to inform our choices here. But all the studies, all the data, retrospective as it was, that I was able to find, seemed to indicate that there was some level of response to chemotherapy from micropapillary disease. And it looked like these responders typically had better outcomes. So I think it's reasonable to consider neoadjuvant chemo in these patients, although we still don't know how to identify who's going to respond, much like with urothelial carcinoma. And in these cases with really aggressive disease, it's a difficult balance because you want to treat this person before their disease advances too far, but it's always sort of a gamble delaying their surgery for chemotherapy. And before I move on to the next subtype, I just want to talk about molecular targets for micropapillary disease, because this is probably the one subtype that we have the most activity in. HER2 is a human epidermal growth factor, which is very well studied in other cancers, particularly in breast, where it's already a target. But there's been increased interest in HER2 in bladder cancer, particularly micropapillary, because a significant amount of this subtype overexpresses HER2, anywhere from 40 to 75% or so from the different journals that I was able to look at. That's in comparison to, on average, less than 10% of urothelial carcinomas overexpress this protein. So there have actually been a couple phase 2 trials with HER2 targeting agents in patients with micropapillary disease. The first one, which was trastuzumab or Herceptin in metastatic micropapillary bladder patients. Unfortunately, they failed to accrue, so their results were non-significant. But a second one, which took patients with all sorts of bladder cancer, but tested their HER2 and EGFR overexpression rates, they did find an overall survival benefit in patients who were overexpressing those receptors, and found that their progression-free survival was 30 weeks compared to 18 weeks in patients who did not receive a HER2 or EGFR agent. Again, no overall benefit. So, it's still early, but potentially it's something that we could be able to target in the future. And in fact, Dr. Black's lab has done a little bit of research into HER2 as well. They looked at TDM1, which is a antibody drug conjugate. It's essentially a cytotoxic drug conjugated to trastuzumab. And they found that in vitro, this was very effective against micropapillary bladder cancer. And in fact, it was more effective than Herceptin or trastuzumab alone. As well, the effect scaled with the degree of expression of HER2 and held true in the mouse model as well. So again, early stages, but this is potentially something that we could be seeing as a target in the future. So I'm going to move on now to small cell cancer of the bladder. Histologically, this looks like, again, I'm going to butcher this, but small clusters of cells with very small round nuclei and what's salt and pepper chromatin, which I vaguely remember from pathology class in med school. It's very similar to small cell lung cancer. This is a urothelial cancer with neuroendocrine differentiation. Oftentimes it shows up mixed with other variants, particularly urothelial carcinoma. Like small cell of the lung, this disease is very aggressive, and it's virtually always muscle invasive. Data from MD Anderson found that 95% of their patients with small cell had T2 disease or worse. 75% of their patients were node positive or metastatic at presentation. Overall survival across multiple samples and studies has been uniformly poor, less than a year usually from diagnosis. So, small cell bladder is not very well studied, but small cell lung is. So I think it'd be interesting to compare the management of small cell bladder to small cell lung. In brief, small cell lung is divided into limited stage or extensive stage. Limited stage disease is that which is resectable or which can be encompassed in one radiation field. So usually like one hemithorax. And patients who have limited disease receive chemotherapy and radiation concurrently. A very, very small subset of low-risk patients can have resection, but the vast majority get chemo and rads. If you're extensive, so meaning you can't irradiate at all safely, then you just get chemotherapy. Similarly, in bladder cancer, there is limited and extensive disease. Limited disease is that which is resectable or within the pelvis and can be caught within a pelvic radiation field. Unlike small cell of the lung, small cell of the bladder, there's a bit more research into surgical management as opposed to radiation, and we're going to talk about that. But first of all, the gist of small cell is that it's a very serious disease, and finding it on pathology almost universally bodes poorly for the patient. Any fraction of small cell on your pathology sample is significant and should be treated like a pure small cell tumor because it's so aggressive and so invasive that you need to manage it differently. Small cell has some unique behaviors that are very in line with what you see in lung. For example, there's a high incidence of brain metastases in small cell, and as well in small cell of the bladder. There's been a higher than normal or higher than expected incidence of brain metastases. So part of your staging workup for a patient who has small cell should be some sort of brain imaging, preferably MR. As well, there's a high predilection to go into the bone for small cell. So a bone scan is actually indicated as part of your workup. In fact, some lung cancer patients with small cell get prophylactic brain irradiation, and some studies have actually suggested considering that for your small cell bladder patients as well. One of the main pillars of treatment for small cell of the bladder is chemotherapy, and cisplatin etoposide is the recommended regimen. In bladder cancer, after chemotherapy, there's usually a consolidative therapy if the disease is localized, and that's either cystectomy or radiation. And we'll talk about those two options. So there's really good evidence for the efficacy of, or well, not really good, but really good retrospective evidence of the efficacy of neoadjuvant chemo. MD Anderson found that the 5-year overall survival in the neoadjuvant chemo group was 80% compared to 20% for cystectomy only. Cancer-specific survival was almost nearly 10 times better. In patients who had PT2 disease or better at the time of cystectomy, so localized to the bladder, they survived very well, 187 months, cancer-specific survival, versus patients who had T3 or node-positive or metastatic disease, they survived less than a year. Interestingly, there was no benefit to adjuvant chemo given the effectiveness of neoadjuvant chemo. And that was something I found on multiple studies, is that adjuvant chemotherapy after surgery for these patients was not nearly as effective as neoadjuvant. Radiation for bladder cancer has not been studied very well, and I wasn't able to find a lot of information. One study I found from the Netherlands was a single-arm retrospective of patients who had chemo and radiation for small cell of the bladder, and this was, they had 17 patients. Overall survival was about 32.5 months. Another paper, actually authored by Dr. Sullivan, from local data, 10 patients with a 40-month median overall survival for patients who received chemoradiation. So, obviously we can't compare directly, but the numbers look decent. It's definitely longer than a year. So, maybe there's some merit to chemorads, but we don't really know is the answer. And because we don't really know, some researchers turn to databases to see if there's any difference between chemotherapy and surgery and radiation for small cell bladder cancer. And one of them from the SEER database found no overall survival difference. You can see there from the Kaplan-Meier curve. There was no difference between cystectomy and chemotherapy versus chemo and radiation. Other researchers looked at the National Cancer Database in the States, and they actually did find a survival benefit for cystectomy and neoadjuvant chemo. And this was superior to chemo and radiation therapy. So what do we do? Chemotherapy or radiation after chemo? Either is reasonable. This is a paper in the CUAJ from the Canadian Medical Oncology, GU Medical Oncology Group. And a lot of the prominent uro-oncologists also signed off on this. Essentially, it says either choice is reasonable, but do chemo first. In terms of targeted therapy in small cell cancer of the bladder, there isn't anything specifically for bladder. There are a lot of markers which are being explored in small cell, or small cell of the lung, excuse me. But unfortunately, there hasn't been a lot of success with small cell lung yet. Recently, there is one new drug, receptor targeting, that has published phase 2 data. They had an 18% overall response rate. This drug, rovalpatuzumab, is a DLL3 antibody, and DLL3 is a protein in the Notch pathway, and that's about all I understood. It's shown some efficacy in lung, and they're going to plan to eventually carry it forward to phase 3 trials. Potentially this is something that could eventually be applicable to bladder. As well, we're doing a lot of work on neuroendocrine cancers here in this center. Dr. Zubeidi's lab has made some really interesting breakthroughs with respect to neuroendocrine prostate cancer. And this is speculation at this point, but maybe eventually some of those neuroendocrine data, that information could be applicable to neuroendocrine cancers of the bladder, like small cell. So next we're going to move on to squamous. Squamous cell carcinoma of the bladder is characterized on histology by keratin. And that's what I remember from medical path. There's keratin deposits, which you don't usually find in the bladder. Before we start talking about squamous disease, we have to make a couple of important distinctions. First of all, if you see squamous cancer in the bladder, you have to make sure that that's actually a primary. It could be local extension from another pelvic organ. It could be metastatic, although metastases to the bladder are really rare. As well, you have to differentiate between a pure squamous carcinoma of the bladder and garden variety urothelial carcinoma with squamous differentiation. It sounds subtle, but the latter is treated the exact same as urothelial carcinoma, and the former you should consider something different. And lastly, probably the most interesting differentiation is bilharzial or non-bilharzial squamous cell cancer of the bladder. Bilharzia or schistosomiasis is a parasitic infection endemic to many areas of the world, Africa and Southeast Asia. The parasite part of the reproductive cycle involves invasion of the bladder, which can lead to chronic inflammation. And in areas with endemic schistosomiasis, squamous cell cancer is extremely common. And the disease behaves a little bit differently, but overall we sort of manage it the same way, and we'll talk about that going forward here. For squamous cancer, because there's such a high incidence in these endemic areas, interestingly, most of our data actually comes from Egypt. So we'll talk first about non-bilharzial squamous cancer. It comprises about 3 to 5%, depending on who you ask, of all bladder cancers. Chronic irritation is the well-recognized risk factor. We always think about the spinal cord injured patient with bladder stones, and long-term indwelling catheter, and multiple urinary tract infections. Like most of the histologic subtypes, squamous cancer carries a worse overall prognosis compared to urothelial cancer. Across all patients, median overall survival is usually listed anywhere between 10 to 12 months. 5-year overall survival is about 26%. It's very prevalent in areas with endemic bilharzia. Up to 60 to 80% of all bladder cancers are squamous in areas with schistosoma. Interestingly, according to some papers, up to 27% of all cancers in places like Egypt were squamous bladder cancer, which is mind-boggling. But interestingly, there's been some interesting population-level studies as increased water sanitation improves, as public health programs with anti-helminthics improves, the incidence of squamous bladder cancer is actually decreasing. These patients tend to present younger, at an age of 46 on average. Typically, it's low-grade disease, but regardless, they tend to present at an advanced stage and have poor prognosis. And this is likely because the symptoms of bladder cancer are pretty similar to schistosomal cystitis. Irritative voiding symptoms, gross hematuria. So a lot of patients present late and have advanced disease. Some Egyptian data found a 5-year overall survival of roughly 50%, but this is in a mixed cohort with only about 60% actual squamous cancer. The management of squamous bladder cancer is the same, more or less, regardless of whether it occurred in the context of schistosoma or not, and that is cystectomy. One of the defining characteristics of squamous bladder cancer is its tendency to recur locally. MD Anderson in the West listed about a 50% chance of local recurrence within about 5 months. And similar data are found in multiple Egyptian series, anywhere from 46 to 60% of local recurrence. And typically when patients recur in the pelvis, they die relatively quickly. So therapies to reduce the incidence of pelvic recurrence would obviously make sense. And radiotherapy has been explored as an option for this, particularly in Egypt where there's a lot of interest in it. It makes sense. Squamous cancers are managed with radiation, or squamous cancers from all other areas of the body are managed with radiation. So it would make sense that these would be effective here. Interestingly, we actually do have a randomized controlled trial, which is probably some of the best data I was able to find in bladder in histological subtypes. And this study from Egypt had 2 different radiotherapy arms randomized against cystectomy. And they had 236 patients. 2/3 of the patients were squamous cancer. And they actually found a significant disease-free survival benefit to post-operative radiation therapy is what they studied here. 44 to 49% of patients had 5-year disease-free survival versus 25% of the cystectomy-only group. And toxicity was actually pretty tolerable as well. Half of patients had grade 1 or 2 diarrhea, which was mild and didn't require medical management. About 1 in 5 needed simple inpatient management or simple hospital medical management for their diarrhea. 3 patients developed fistulae and died, however. Another study out of Egypt on post-operative radiotherapy was also prospective, but this time not randomized. They actually again found a disease-free survival benefit, 26 months versus 18 months on average, for post-operative radiation therapy after cystectomy. Again, side effects were tolerable. Half had some diarrhea, but there were no severe effects. And you can see the Kaplan-Meier curve here. The top line is the post-operative radiotherapy group. The bottom line is cystectomy-only group. You see a significant benefit in disease-free survival. As well, there was some data out of MD Anderson, of course, about radiation and squamous cancer. They actually tested preoperative neoadjuvant radiotherapy. It was single arm, but they did find 87-month median overall survival. Interestingly, though, despite the radiation, 1/3 of these patients still recurred in the pelvis. And so recently, there's been a RCT out of Egypt, actually published within the past several years, that examined neoadjuvant versus adjuvant radiation for squamous bladder cancer. And interestingly, they found no difference. So their conclusion was that you should give some radiation, but neoadjuvant versus adjuvant, you could take your pick. Quick note about chemotherapy in squamous cancer. We don't routinely offer it. Squamous doesn't tend to be very susceptible to chemotherapy. However, there was one interesting study I looked at out of Egypt that compared a neoadjuvant course of epirubicin as well as a postoperative course of epirubicin to cystectomy alone. And they actually found a significant 2-year survival benefit. There was no follow-up on that, though, and I haven't found any data since, so it obviously didn't make much of an impact. So the last subtype we're going to talk about is bladder adenocarcinoma. So histologically, adenocarcinoma is defined by presence of glands. You can see sort of the columnar cells lining these glands. They comprise about up to 2% of all bladder malignancies. Again, you have to differentiate between a primary adenocarcinoma in the bladder or a secondary or a metastatic. There is pure adenocarcinoma and urothelial cancer with glandular differentiation. Again, the latter is treated more or less the same as garden variety UC, so you don't really change much, but adenocarcinoma is different. And the last distinction is a urachal adenocarcinoma versus a non-urachal adenocarcinoma, which we're going to get into. So, first of all, non-urachal adenocarcinoma. It's, like many histologic variants, has poor survival compared to urothelial. 5-year overall survival from multiple studies was about 35%. Median survival, about 30 months. There was more disease, which was outside of the bladder on cystectomy in a SEER database study. So they found that 65% of patients who had adenocarcinoma, primary adenocarcinoma of the bladder, had non-organ confined disease versus 51% who had just urothelial cancer. And this was in patients who were receiving cystectomy. Interestingly, though, when they stage matched the adenocarcinoma patients and the urothelial carcinoma patients, there was no cancer-specific mortality benefit. So again, there's a story of an aggressive disease that tends to present later, but behaves similar to a stage-matched urothelial carcinoma. The management of choice for adenocarcinoma is cystectomy at all stages. There's no role for intravesical therapy. From the National Cancer Database, there was a 40% 5-year overall survival. From this database, they managed to pull and stratify patients based on their treatment. So cystectomy and radiation, radiation alone, and no treatment whatsoever. Unsurprisingly, cystectomy and cystectomy plus radiation were superior to no treatment, but radiation alone was not superior to no treatment. So, you should be operating on these patients. There's a little bit of data on adjuvant radiotherapy for adenocarcinoma. This study came out of Egypt as well. They found a 5-year disease-free survival benefit in adjuvant radiotherapy with 70% of patients having mild toxicity. There's not a lot of data on this, though, so it's really hard to make a recommendation from a single retrospective study. So now we're going to talk about urachal adenocarcinoma. And this is a unique variant that actually arises from the urachus. Quick embryology refresher. The urachus drains the allantois in utero and drains into the umbilical cord. This typically regresses at birth or shortly after. Incomplete regression gives rise to one of 4 different anomalies. There's a patent urachus, a urachal cyst, a diverticulum, or a sinus. These are pretty rare. They only comprise about 10% of all bladder adenocarcinomas and about 2.2% of all bladder cancers. By definition, because they arise from the urachus, you'll see them in the dome. And that's one of the clues that you can be dealing with a urachal adenocarcinoma versus a primary cancer, is that you have no minor urothelial change, but a single tumor in the dome. Because this disease is not technically of the bladder primarily, you can't apply regular bladder TNM staging. There's no agreed upon system, but in the literature, an old classification system put forward by a doctor named Sheldon seems to be pretty popular. So as you can see here, they stratify it by stage 1 disease as disease confined to the urachal mucosa, Stage 2 is confined to the urachus itself. Stage 3 is disease which invades the adjacent structures like the peritoneum, the bladder, the abdominal wall, or any other abdominal viscera. And stage 4 disease is node positive or metastatic. These patients tend to present younger, 56 years old on average. They do have a better 5-year overall survival than non-urachal adenocarcinomas. However, compared to urothelial carcinoma, these patients still do more poorly because histologic variants almost universally do more poorly. MD Anderson had a series of patients with urachal adenocarcinoma. They found a median overall survival of about 46 months. The management of urachal adenocarcinoma is different than the rest of bladder cancer, and it's the only one in which a partial cystectomy is a reasonable first-line management choice. So this involves resection of any involved bladder, the urachus itself, and a pelvic node dissection. Multiple studies have looked at this versus radical cystectomy, albeit retrospectively, and they found that there's no survival difference between patients who had this partial resection of the bladder versus radical. So as of right now, the consensus is that it's reasonable to go ahead with a partial cystectomy as long as you can get adequate margins. Now, the question of whether or not to take the umbilicus is something that's worth discussing. I think historically it's been taken because it's been in continuity with the urachus, and the alternative was to either take the bladder or to take a partial with the umbilicus. So, I think just sort of propagated forward through the literature has been the idea that you take the umbilicus. MD Anderson recommends it because 13 of their 16 long-term surviving patients had an umbilectomy, which is not particularly strong evidence, but that's what they say. The Mayo Clinic also recommends taking the umbilicus based on no justification. There's no overall survival benefit to taking the umbilicus and no real strong evidence to support it. I talked to Dr. Black. Well, we talked about this with Dr. Black last Friday at Half Day, and I think Dr. Black, you agree, you feel that you don't necessarily need to take the umbilicus if you can get a good margin, which I think is reasonable.
Talk about margins. I think these historical series are often big bulk.
Mm-hmm. Exactly. So, yeah, exactly. It's a relatively, it's a cosmetically significant procedure. And just briefly, there's very little evidence in this rare subtype, and there's nothing really to support any sort of neoadjuvant or adjuvant therapy, radiation or chemo. So as of right now, we do this for partial cystectomy. So I just want to talk briefly about pathology and the histologic variants. As we've talked about, and hopefully you agree, variant histology alters your prognosis significantly. And so identifying it is of major importance. However, there's been several studies now that look at concordance between diagnosis on TURBT and diagnosis on cystectomy, and they find that there's not a lot of good agreement, especially in the histologic subtypes. This is one graph, which is kind of hard to interpret, so I'll walk through it. In the columns is what was diagnosed at TURBT, and in rows going horizontally is what was diagnosed on cystectomy. So you can see here in the first box of 78 micropapillary tumors on cystectomy, of 78, 59 were diagnosed on TURBT as urothelial disease. And of the 78 micropapillary tumors, only 10 were actually called micropapillary. And this is, I think indicative of the data in general. The bottom row is the Kappa agreement index between TUR and cystectomy. And, it goes from moderate for things like small cell and squamous, moderate being 0.6 with 1 being perfect and 0 being no agreement. But agreement is relatively poor for subtypes like micropapillary disease at 0.1, and having any sort of diagnosing any sort of variant histology at all, agreement is about 0.3. And the data from this study in particular were from a center where everything was examined by a dedicated GU pathologist. So we're not getting great agreement, and we're not necessarily getting good recognition And I think there's probably several reasons for that. First of all, a TURBT is just a sample of a greater tumor, and you can have focal disease that exists elsewhere in the bladder, but you just don't identify it. And none of these subtypes are really identifiable visually, so you don't necessarily know what you're getting. And depending on who does the TURBT, the sample may or may not be fried to a crisp, as Dr. Black, my experience, has commented on. As well, I think a lot of these, and I really appreciate some input from the pathology side of things. I imagine that the histology can be very subtle, and if you're not seeing this every single day, it can be easy to miss a small focus in a larger field of regular urothelial carcinoma. So basically the take home from this is that pathology, it's difficult to find these things, and that's suboptimal at this point because we need to know about these things because they change management. So in terms of take home points, how do I manage these subtypes if I see them on my path report? For micropapillary, you do cystectomy, you consider neoadjuvant chemo. Maybe BCG, but it's risky. For small cell, neoadjuvant chemo is a necessity. Then you can go with cystectomy or radiation. Either is reasonable at this point. For squamous cancer, cystectomy is your treatment of choice. You consider perioperative radiotherapy before or after. And for non-urachal adenocarcinoma, you do cystectomy. There's a little bit of evidence for radiation, but not a lot of evidence. So really, your pillar is cystectomy. And for urachal adenocarcinoma, you do a partial with the umbilical stalk. And that's my presentation. Thanks for listening. Thank you to Dr. Black for the